You're welcome to my channel. Thanks for visiting, subscribing, sharing my presentations, and listening to this very one. Today, I'll be focusing on severe malaria. Severe malaria. Types of fever in malaria. We will not be able to understand this fully or enjoy the presentation fully without having thorough knowledge, as per Plasmodium life cycle. And if you want to get that done, please kindly click on this very link. Because Plasmodium life cycle involves stages in the mosquito and stages in humans. And they are all right here. Just click on this link. The hepatic stage will have no signs and no symptoms. The erythrocytic stage is when we'll be dealing with signs and symptoms of malaria with the cyclic lysis of red blood cells as trophozoite completes its cycle, and that will lead to the signs and symptoms. If the life cycle is completed every alternate days, we will have the situation known as tertian fever. If the life cycle is completed or the situation is mild fever that is reoccurring at every 3 to 4 days, for example, on Monday fever, then on Thursday, then on Sunday, the condition is known as quartan fever. Now, quartan fever is mild fever, but will be reoccurring at every 3 to 4 days. So, like I've just said, on Monday, then on Thursday, then on Sunday. Quartan fever is found in Plasmodium malariae. Benign tertian fever. Fever here occurs at alternate days. For example, on Monday, then Wednesday, and then Friday. Mostly benign or non-fatal, and we'll find that in Plasmodium vivax and Plasmodium ovale. The benign form of the tertian fever is the commonest type. Then, if we say something is benign, then do we have malignant? Yes, we have malignant tertian fever. Although still occurring alternate days, or sometimes the fever may be persistent anyways, the term malignancy, or to say something is malignant, means that it could be very, very deadly, that is fatal, be dangerous, difficult to treat, and you may be dealing with multi-drug resistance. So you're going to find this malignant form in Plasmodium falciparum. It is the most deadly or the life-threatening form of malaria. Now, severe malaria, we have just gone through. Already by now you have clue which type of the Plasmodium will likely give us this. Of course, it will be Plasmodium falciparum. So in severe malaria, peripheral blood smear will show us the presence of parasitemia. Of course, it's not going to be malaria if we don't find parasitemia, right? This time, mostly it will be Plasmodium falciparum. That will be the main agent in severe malaria. But picking this on peripheral blood smear is not alone and enough or the only factor to define severe malaria. There are other clinical features that we have to pick. So I will go through the list in a bit. Once you find one of them or more, in addition to parasitemia on peripheral blood smear, which is likely going to be Plasmodium falciparum, then you are dealing with severe malaria. Okay, Plasmodium falciparum on peripheral blood smear. In addition to that, cerebral malaria, then it is severe malaria. Or hypoglycemia in addition to that, impaired consciousness, hypotension that is not due to other reasons, Hypoglycemia too here must not be due to other reasons, and impaired consciousness must not be due to other reasons also. Okay, severe anemia must not be due to other reasons: pulmonary edema, shock, hyperparasitemia, multiple organ failure, not due to any other causes outside malaria. Then we're dealing with severe malaria. Okay, your peripheral blood smear is revealing parasitemia in addition to jaundice, frustration, convulsions, acidosis, disseminated intravascular coagulopathy that is not due to any other causes outside malaria. Then it is severe malaria. If that malaria will lead to bleeding, hematemesis, melena, renal impairment, or tachypnea, it is severe malaria. Parasitemia threshold. For Plasmodium falciparum, if it's greater than 10%, for Plasmodium nollis, if density is greater than 100,000 per microliter, but for Plasmodium vivax, it has no density threshold. On physical examination, we have to get general examination done, full neuro, cardiovascular system, respiratory system, the abdomen, the skin, because we've gone through the list now, right? That there could be hypotension, there could be shock, there could be jaundice, there could be, loss of consciousness, convulsion, and so on. So how are you going to get that done or established without doing all these things? Okay, now treatment. First thing first, resuscitate as the presentation may require. Airway, any foreign body, secretion, bleeding, exhibiting, suction as appropriate. Breathing, what's the respiratory rate? Is the chest moving with the abdomen? Any obvious deformity, cyanosis, peripheral or central? What is O2 sat? Circulatory system, what is the capillary refill status? Volume, any dehydration? What is the BP? What is the heart rate? Any edema anywhere? Then move on to O2 sat, of course, part of the respiratory system, right? And of course, the vital machine should be hooked up because we need to monitor the entire state of this patient. ABG, arterial blood gas. Someone is asking why. Yeah, acidosis could dictate the level of severity. Okay, preparation for intubation if so required, bladder catheterization if so needed, IV fluid must be set up, pulse oximetry, ophthalmoscopy. Okay, now on medications to use immediately, we have to go for intravenous anti-malaria agent. If we don't have one, might be because we're in remote parts of the community or the state or the province, then you can use the rectal form or you grab your intramuscular injectable agent. If there is convulsion or seizures, give your anticonvulsant, but benzodiazepine first, then analgesic to handle the temperature, transfusion depending on the level of hematocrit or hemoglobin, glucose depending on the value that may teach you to use D50 or D5 water, and of course antibiotics as the case might be. Now, investigations. First thing first, peripheral blood smear for malaria parasite, without which we will not be able to make that determination that the problem we are dealing with is secondary to malaria. Okay, so we establish that first, then we'll go ahead to know the value of the glucose, the complete blood count, differential white blood cells, electrolytes, renal function test, what is happening to the liver, group and cross match. Someone will tell me you don't need that. Well, it is better you get that done, particularly if you are not in a higher center where you can get this thing done quickly enough and rescue the patient. Okay, it is better you get that done and get your mind set that you may run into bleeding in this patient and you might need blood transfusion, depending on what you have here from complete blood count. Clotting profile, what is happening? Are we running into DIC already? Lumbar puncture, when you get the CSF, have full analysis done. Then LDH, arterial blood gas because of possibility of acidosis, and of course, urinalysis. Still on treatment, determine whether or not the journey will proceed to intensive care unit. And of course, whether there will be intubation or not. Okay, intravenous anti-malaria agent. First thing first, Artesunate. That is the first choice. I'm not an agent selling Artesunate. I'm not against other medications, but truth be told, right? Then you can grab your intravenous quinine if Artesunate is not available. And I will reluctantly use either quinine or quinidine. I will always go for Artesunate first. You may give intramuscular Artesunate if you don't have intravenous Artesunate. You can give intravenous Artemether. In fact, that will be the last that I will give here because absorption here will be erratic. You will get that in a bit. Now, intramuscular agent like Artesunate, if that is what is available, then give that 3 milligram per kilogram per dose if the patient is less than 20 kg. But if he or she is greater than 20 kg, go for 2.4 milligram per kilogram. Okay? If you are using Artemether, let your loading dose be 3.2 milligram per kilogram start. Intramuscular quinine should be 20 milligram per kilogram. But listen, you can do something different here. Some will give these, via gluteus maximus. No. Why that? You will know in a bit why we will not give quinine, at the gluteus. Why? It can damage the sciatic nerve. So divide the total dosage of quinine into two. Give half into each of the thigh. Now you can use rectal Artesunate at 10 milligram per kilogram in less than 6 years old if you are not in a center with the availability of the technical know-how, enough competent people around, and you have medication around, you are in a remote place, and all you have is suppository type. Oh, go ahead. Artesunate absorption via the suppository route is also good, but make sure you are adding to good centers where they can give intravenous agent. Okay, IM medications or rectals are welcome if intravenous agents are not available. That is in the absence of IV agents that you give your rectal or IM medications. You may use per oral if the patient is not vomiting, but you must switch to intravenous agent later on. Referral to the appropriate centers is required or until oral intake is possible. If Artesunate is not available, you can use quinine. But like I said the other time, many people will not use quinine nowadays. Why that? We're afraid. What are we afraid of? Of course, prolonged QT that will lead to fatal arrhythmia. How about that? Okay, from prolonged QT can degenerate to tozadipine. From tozadipine can degenerate to tachycardia, ventricular tachycardia, monomorphic, then polymorphic, and going downhill to ventricular fibrillation. If there's no defibrillation, can degenerate to asystole. If asystole is occurring within the hospital setting, could blue fast. If it's on the field or somewhere else, then you call 911. And if advanced cardiac life support is not instituted quickly, the patient will end up in the morgue, meaning death. And of course, not only the fatal arrhythmia that is so scary to many of us, there might be severe hypoglycemia from hyperinsulinemia, all from quinine and quinidine. So, if I find my way home, I won't even go near it. Still on treatment, Artesunate Combination Therapy like Artemether lumefantrine could be given. And the details of that can be found here if you click on this link. Okay, you can have prophylaxis with Primaquine to handle the gametocytes and hepatic schisms. Full info on Primaquine is right here. You can click on this link. Pregnancy should attract artesunate, and then if that is not the case, then you can give Artemether or Quinine. Seizures should be aborted with lorazepam or diazepam, and you can give that intravenously or intraosseous or rectally. If you are not winning, then you can grab your paraldehyde that could be given intramuscularly. You then change to per once it can be tolerated. Per artesunate, you can get full details right here if you click on this very link. No, it's being published right here. You can also get per Artemether lumefantrine if you click on this link, and also Atuvacum proguanil if you click on this link. Okay, if per agent that we're going to use is quinine, and you want to know more about quinine, you can click on this very link. This is not a link to quinine alone. It is a link to the list of all anti-malaria agents, but I have provided lots of pieces of info on quinine right here. If your choice is mefloquine, or you want to know more about mefloquine, please kindly click on this link. If your per agent is Primaquine to clear the hepatic schism, please, you need to know more about Primaquine, right? If that's your choice, please click on this very link. Now, transfusion will be determined based on what is obtainable in your jurisdiction, but generally, when hemoglobin reaches less than 7 grams per dl or hematocrit is less than 20%, begin transfusion. If you want to give packed cell volume, it should be around 10 mL per kg. But if your choice is whole blood, it should be 20 mL per kg. A chain transfusion will be very helpful if your center can do that, because that will enhance parasystemia clearance. Because by the time you take that blood in the patient out, you are taking it out with the parasites, and then you are transfusing fresh blood without the parasite. So a chain transfusion will be very, very helpful to clear the parasite. And you can feed with NG tube. Acetaminophen will be very helpful, and you can give that at 15 milligrams per kilogram every 6 hours to handle the temperature. If this patient with malaria is also down with HIV, cordimazole, that is Bactrim or Septrin or Septra, will be helpful in this situation. If there's associated bacteria, because maybe you have done your MCS or you're just suspicious, you can grab your Clindamycin or Doxycycline. But Clindamycin will likely give Clostridium difficile or C. diff with diarrhea, or Clostridium difficile, that's the new name. Why Doxycycline is contraindicated in children, in pregnancy, and breastfeeding mothers. So if you are dealing with a pregnant mother and children, maybe you go for Clindamycin. If not, then you use your Doxycycline. Finally, we need to round off the treatment with monitoring. Peripheral blood smear should be done every 12 hours or at least once daily, every 24 hours. Let's know the complete blood count. Some will call it full blood count, some will call it total blood count. And of course, hemoglobin level. That should be done every week for 4 weeks. Vital signs should be monitored very closely. And of course, the general well-being of the patient. We are not treating the papers, we are not treating what is on our computer screens, we are not treating the lab or the lab reports, we are treating fellow human beings, but the parameters from the lab will help. So if the patient is well, the patient is well. But we should also remember the good treatment will involve taking the correct medications at correct dosage for the appropriate number of days or weeks. Thanks for listening. Remember to share this. Remember to subscribe to my channel. And let me leave this. If you have picked a new drug or a new pattern right now, which is not done in your center, it is nothing bad to do something that is great. For example, in some regions of the world, quinine is no longer a good medication to treat severe malaria. And even some are pretty much afraid to prescribe quinine because of the side effects. Then, why not telling the government to help you out by going for Artesunate? Thanks for listening. Remember to share this. I appreciate it.